Good morning, everyone. I'm here with you for the ASCO Direct Highlights St. Louis, and I will be discussing the HPV oral presentations. My name is Heloisa Soares. I'm a GI medical oncology, and I am the co-physician leader for the GI Clinical Trials Research Group at Huntsman Cancer Institute at the University of Utah. And I selected 5 trials to talk to you, and the first 4 will be in upper GI. The first trial that I would like to comment on is the abstract 4004, which was entitled, in short, Neo-AEGIS, which is the Neoadjuvant trial in adenocarcinomas of the esophageal or GEJC International Study. Preliminary results of the phase 3 randomized trial of CROSS versus perioperative chemotherapy in these patients. This trial was a trial that took some time to enroll. There was a trial that also had to have changes during the trial in terms of design from a superiority trial to a non-inferiority design. Also, in 2018, amendment in this trial was done to add FLOT as a potential perioperative systemic option rather than just the backbone per the MAGIC. And patients were randomized to receive chemoradiation followed by surgery versus perioperative systemic treatment per investigation discretion, either per MAGIC or per FLOT, and then they will follow. So the trial concluded that perioperative chemotherapy was not unacceptable inferior to CROSS regimen multimodality, with a 3 years overall survival of 57% and 56%. And the curves really were pretty similar in terms of median overall survivals and the whole curve. What was interesting in this trial, there was pathological responses were higher with the chemoradiation group, including nodal downstaging and R0 resections with the chemoradiation arm. And there was no difference in terms of severity of complication and specific index of complication rates, which was one of concern that perhaps chemoradiation could lead to more complications. There was really no difference between the groups. That was the first study. Then the second study that I wanted to talk about is the Checkmate 577 that was initially presented at ESMO last year, and essentially is about adjuvant use of nivolumab in patients that receive chemoradiation in the neoadjuvant setting, underwent resection, and then had nivolumab after. And to summarize, this was a positive trial. Adjuvant nivolumab demonstrated a clinical meaningful efficacy in patients with resected esophageal cancer and GEJC cancers following the neoadjuvant treatment compared to placebo. And this is based on disease-free survival. We don't have overall survival data yet. And the data show a 31% reduction in the risk of recurrence or death and a doubling in terms of median disease-free survival from 11 months to 22 months, if I recall correctly. The disease-free survival benefit was consistent across several pre-specified subgroup analysis. There was also less distant progression-free survival disease, as well as less local regional recurrences. And there was also improvement in progression-free survival too. Not only that, but adjuvant nivolumab demonstrated acceptable safety profile and maintained the quality of life of patients, with similar trends in quality of life along the treatment. So this study actually supported the further use of adjuvant nivolumab as a new standard of care for patients with resected GEJC or esophageal cancers that follow neoadjuvant chemotherapy and had pathological residual disease, either by still having the presence of a T1 tumor at surgical pathology report or positive lymph nodes. Then the other trial that I want to talk to you was the Checkmate 649, which was a first-line trial of nivolumab plus chemo versus chemo in advanced gastric G-junction or esophageal squamous cancers. The third trial that I want to discuss with you is the Checkmate 648, which was essentially nivolumab plus ipilimumab versus nivolumab plus chemo, or chemo as the first line for squamous cell esophageal carcinoma. And this was important study because it was the first study to show that nivolumab demonstrated a superior overall survival benefit and durable response in combination either with chemotherapy by itself as the backbone or with regimen without chemotherapy, just between nivolumab and ipilimumab compared to chemotherapy alone in patients that were previously untreated for advanced esophageal squamous cell carcinoma. There was a statistically significant and clinically meaningful overall survival benefit with nivo plus chemo or nivo plus ipi for patients who had tumor cells expressing PD-L1 of 1% or more, and in all randomized patients. There was also a clinical meaningful progression-free survival benefit and higher overall responses with patients that had nivo plus chemo and longer durations of response with nivo-containing combinations. No new safety signals were identified with the nivo plus chemo or the nivo plus ipi. They were surprising. And both nivo plus chemo or nivo plus ipi each can represent a new potential first-line standard of care for patients who have advanced esophageal squamous cell carcinomas. The next trial that I wanted to discuss is the Checkmate 649, which is a first-line use of nivo plus chemo versus chemo alone in patients with gastric cancer, esophageal cancer, or G-junction adenocarcinomas. And this trial showed that nivo plus chemo was superior in terms of overall survival compared to chemo alone, with also clinically meaningful progression-free survival benefit and durable responses in patients with untreated disease in the metastatic or locally advanced setting. Nivo plus chemo had acceptable safety profile and no new safety signals were identified. Treatment-related adverse events with potentially immunogenic etiology were resolved in most of the patients, just establishing the usual management algorithms. And grade 3 to 4 adverse events were less than 5% in both of the patients. The treatment of nivo plus chemo maintained the quality of life of the patients, and importantly, there was a decreased risk of symptom deterioration with the use of nivolumab. And none of the treatment arms affected in terms of the bothersome of the chemotherapy of the treatment side effects. There was no worsening of that with the addition of nivolumab to the treatment. So this data support the use of nivo plus chemo as the new first-line standard treatment for patients with advanced no HER2 positive gastric G-junction and esophageal adenocarcinomas. Finally, I want to talk to you about the abstract 4006, which is about the use of nal-IRI with 5-FU versus 5-FU alone in the metastatic biliary tract cancer setting after progression in GemCis. This was a multicenter comparative phase 2 study called NIFTY. The trial showed that nal-IRI plus 5-FU significantly improved progression-free survival of these patients, as well as overall survival and objective response rate in patients after progression on GemCis compared to 5-FU alone. Not surprisingly, patients had more adverse events with the addition of liposomal irinotecan, but the adverse events were very well managed and similar to the ones reported in the Napoleon trial. One caveat of this trial is that this trial was only conducted in Korea, and most of the patients were from one institution, about 80% of the patients. So whether we can fully extrapolate to the Western population remains to be seen. Having said that, it's very reasonable to consider nal-IRI plus 5-FU as one of the new or was an option for standard of care treatment in patients with biliary tract cancers after they fail gemcitabine and cisplatin. And that's what I have for you. I hope you enjoy the rest of the meeting. Thank you.